Right, so my name's Emily. I'm one of the F1s who's working in respiratory at St James's. I might have actually met a couple of you. I think there's a couple I recognise. Basically, guys, the more interactive you are, the better this will work. So I hope you find it useful. I'm not a Leeds grad. I graduated from Norwich. It's one of the newer medical schools, and we did like 17 OSCEs over the course of our 5-year course. So yeah, I know, literally so many, it was silly. And by finals, I'm always a bit bored of them, to be honest. But so I kind of hope I can put my experience of many, many OSCEs to help you guys out. Okie dokie. So basically, we'll just go through like a set of sort of sample scenarios, and then I'll just choose sort of like individual tips for acing finals at the end of each scenario, and then just a whole load of sort of points that I've sort of come up with over the years at the end. I hope you find it useful. Please interrupt at any point with any questions or anything you want to discuss. Is that all right? Okay, so the first station is an alert station. So you're the F1 in A&E, and a 25-year-old woman arrives acutely short of breath, brought in by ambulance. The paramedics have been useless, haven't done anything, and her notes are not with you, and you're asked to urgently assess her. So what are you going to do first? Perfect. Excellent. The one candidate that won't say that will be the one that will stand out from the crowd. So as long as you say the obvious and not the one that stands out from the crowd, that's brilliant. Okay, so Airway, what are you going to do? What are you assessing in Airway? Exactly. Yeah, excellent. And why are we wanting to know if they're talking to you? Perfect. So, this patient is talking to you but unable to complete full sentences. What are you going to say at this point? Yeah, that's a useful question, but if you've got an acutely unwell patient in front of you, what do you like to do? After you've assessed someone, what are you then going to do? Yeah? Within each of the A, B, C, D, E sections, I tend to like to think of it in terms of your assessment first, and then what you're going to do to treat that part first. Okay, so before you move on, you must treat that portion. Yeah? So what are you going to do in A? No, you're very right. Exactly, yeah. So you're going to give her, what are you going to give her oxygen-wise? Perfect. So I would like to place her on oxygen 15 litres via non-rebreathe. Okay, so in A, any acute scenario, it doesn't matter whether their airway's patent, whether they are completely comfortable at rest, you put them on 15 litres of non-rebreathe oxygen. It's really that simple. Okay, so we move on to B. What are you looking for in B? Yeah. Yeah. Perfect, yeah. Lovely. Okay. So this lady's got a respiratory rate of 35. She's peripherally cyanosed. She's saturating 75% on air. Her trachea's deviated to the right, and she's hyperresonant on the left side. And she's got reduced air entry on the left. What are you going to say at this point? Get me a cannula. Yeah. Why are you going to say get me a cannula? Yeah. I think this patient has a tension pneumothorax. It's all about playing the game. Okay? All right. So you've done your assessment and you've come up with the diagnosis. What are you going to say now? It's what you said previously. So I'd like a cannula, and what are you going to do with it? Perfect. And what are you going to do with it once you put it in? Yeah. And then what are you going to do? You've got your Yeah, yeah, that's very, very useful. But are you going to put it in and take it out? Are you going to put it in, leave it there? Yeah, so once you put it in, it's important you leave it in and that you tape it down, okay? Because these patients could potentially tension again and could have a reaccumulation of the air, and you're effectively saving their lives just by having that simple cannula in, yeah? Okay, so I would like a wide bore Venflon, insert it into the chest wall until I heard a hiss in the second intercostal space, midclavicular line, just above the rib. Why do I say just above the rib? Perfect, you guys know everything. Now you would go back to A, because at every stage, I just think if you say this at some point in the assessment, it shows that you're thinking of it. I know that this is a very time-pressured situation, and you don't always have time to go back to A, because what happens if the problem's in D, you know? But if you're making a massive change at some point, if you just say, I'd like to go back to A, because ultimately you could be causing an intervention that could compromise A. And A would ultimately kill you quicker than B, and B would kill you quicker than C. See what I mean? So I would like to go back to A as I've carried out an intervention. And they'll go, yeah, yeah, yeah. Move on. Okay? So at this stage, it would be quite appropriate to do a gas. And as you said, it would be appropriate to do a chest x-ray once the patient's stabilised. We never do chest x-rays with tension pneumothorax, as you'd said previously. So, very barn door obvious thing here, but can anybody interpret it for me? Lovely. Can you present it to me as you would in finals? Mm-hmm. Perfect. Lovely. Wonderful. Mm-hmm. What, this here? Here? Yeah, that's the brush shading. Excellent. Perfect. Textbook, that's absolutely brilliant. What I would recommend to do in finals is always to start that way when someone gives you a scan or any data to interpret, and if they don't want you to waste time doing that, then they'll go, yeah, just give me the diagnosis, or they'll hand it to you and go, give me the diagnosis. But if you always have it in your head that that's kind of the default, because you don't want to be in the situation where you just go, yep, that's a tension pneumothorax. And of course they know that you know that, but it's a test of whether you're safe, that's it, really. And you could miss the vital marks in, there'd be one mark potentially for saying tension pneumothorax, but so many more that will have been missed in the interim if you don't. But be prepared to just be asked to do spot diagnoses. But that will be kind of guided to you by the examiner. So, yeah, that was brilliant. I couldn't have put it better myself. Excellent. Okay, so move on to C. What will we check for in C? Yeah? Mm-hmm. Yeah, perfect. Lovely. Yeah, perfect. So, she's tachycardic, hypotensive, capillary refill's a bit prolonged, and heart sounds are normal. What would you like? Yeah? Yeah, very good point. Pardon? Yeah, that would be great. Yeah. Yeah, perfect. Anything else you'd like? ECG would be lovely, yeah. So for literally every patient, when you get to these stations, you must think about your assessment and then the investigations you want to do and whether any treatment is appropriate in that section. Okay, so in breathing you need to do an ABG and you need to be asking for a chest x-ray. You might just do a treatment beforehand if it's something like tension in the thorax, but you need to be adding in investigations at each stage. In circulation, the investigations you need to be asking for are, you would like to put every patient pretty much on cardiac monitoring, and you would like a 12-lead ECG. You'd like to get IV access, and it may or may not be pertinent to give them IV fluids. Yeah? Does that make sense? Yeah? Cool. So, cardiac monitoring and 12-lead ECG, and you'd like some bloods. Yeah, that's the other thing that you must do in every case. Okay. Here's your ECG. Could somebody else interpret this for me? Any volunteers? None? Go on. Getting close to final. Am I going to have to pick on someone? Yeah? I'm sorry, I don't know anyone's names. Can I do... How about the lady on the outside at the back? Sorry, no. I'll let you off. How about the chap in the white shirt next to her? Oh, go on. Remember to bring your glasses to finals. Yeah, yeah, yeah. Mhm. Yeah, lovely. Mhm, mhm. Mhm. Just over 120, 130 odd, yeah? 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 I'd say that's normal. Yeah. Yeah? Mhm. Mhm. Yeah. Yeah. I'll let you off that one, sorry. Yeah, that's great. Perfect. So what are you going to say to summarise? If you were asked to spot diagnosis, and you've done a perfect run through, but if you were asked to spot diagnose, what would you say? Perfect. Yeah, with sinus tachycardia. Yeah, lovely. That's what it's showing. Brilliant job. Okay, so that's the end of that scenario. The tips for this one. It is just about being methodical. You do need to be quite quick, was what I found, because you want to get onto the stage for treatment. Once you've reached the stage where there's, it's obviously a disease affecting that stage, then you can breathe a sigh of relief, if you see what I mean. But don't go so slowly that you can't get there, is what I'm saying. It is important, however, to be methodical and to not miss obvious stuff. But I would really familiarise yourself with SimMan and practice on each other as well. It's very, very useful to do that. Do you guys not have SimMan? Yeah. SimMan's like the fake person, the dummy. Like, learn where the speakers are, where you're to listen for heart sounds, where to listen for breath sounds. He's the guy who goes, "I'm so poorly," in a really robotic sort of voice, and "ouch, that hurts," and all that kind of stuff in an American accent. Anyway, remember when you change something, you need to go back to A, because you could have compromised the airway as a consequence. Yeah, and that's about it really. 2, making phone calls. This is an interesting station actually. I quite enjoyed it. So it was sort of a tag-on in ours to the alert situation, in that the assessment that you've just made, you then have to go and refer that patient to the appropriate specialty. Okay, so I hope you guys are all familiar with SBARD. Perfect, excellent. So essentially what you're being asked to do is, after stabilising them, you need to refer them because you're the F1 in A&E. Okay, so you need to make a phone call to the respiratory reg, okay, and ask them to assess the patient. Can you pick one of you, person next to you, to be the respiratory reg and try and make that phone call, and then we'll run through it? Is that all right? I'll give you a couple of seconds. Okie dokie guys, we're nearly there? Shall we run through it? No? You've got to hang up now. The line's gone dead. Right. We'll just run through it, but I'm hoping you kind of did something like this-ish, obviously with variations. So, hi, my name's Emily. Emily Clark. That's something you've got to do. First name and surname. We used to get docked marks for not doing that anyway. I'm one of the F1s in A&E, calling on extension blah blah blah. Am I speaking to the respiratory registrar? There is a female in A&E who's coming acutely short of breath, and I was wondering if you could assess her, please. She's 25 years old, and unfortunately her medical note's not available at the moment. Makes this much, much easier. A. When she came in, her airway was patent, talking in complete sentences. Her respiratory rate was 35, and she was saturating 75% on air. She was resonant on the left, with reduced air entry. She had evidence of mediastinal shift and was shocked. Clinically, she had a tension pneumothorax, so a wide-bore ventilon was inserted and taped down. She has since stabilised. Please would you come and review this patient urgently, as I feel she will need a chest drain. So D, just so I know I've heard correctly, you would like me to gather the equipment to assert a chest drain, and you'll be here in 15 minutes. Okay? Now these are the pointers. I think it's quite, well, it was at least made quite clear to us where the marks would be in stations like this. You need to say who you are. You need to say where you're calling from. We were advised to give an extension number so they can get back in contact with you. Seems a bit excessive, but, you know, never mind. You need to be succinct. You need to get the salient points across without waffling and missing out sort of erroneous, unnecessary details. They will put up a fight to come and review. This is what happens in real life. As soon as you're an F1, you'll realise, you've really got to convince someone to come from their department to come and review your patient. So you've got to sell it, and they will put up a fight. That's what they're sort of briefed to do on the other end of the phone. So don't take no for an answer. And what they're also assessing is your ability to be able to know what the next stage of management is. So they will say to you, why do you want me to come and see her? What are you wanting me to do about it? Okay, so that's obviously not what would be necessarily done in a in the real world, if you see what I mean, because you're asking for that person's opinion, but in this situation they're wanting to know that you know what's coming next. Yeah, so it's good if you can volunteer that information. Okie dokie. And then you should always summarise what you've discussed at the end of the phone, and get a time frame for when they're going to come and see them. Okay, and ask them, is there anything else that they would like you to do in the meantime? And that's it in a nutshell, really. I don't think there's any much more than that. So when you're doing your practice at home, I do exactly this. Come up with a scenario between each. We used to pretend one person to be poorly and make up signs, and then you'd have to talk to them on the phone about it afterwards. And it's good. It's just good habit. It's just a good practice to get into. And if you've already made up the scenario, it doesn't take that much more time to just make a quick phone call about it. You look very silly there if someone comes in the meantime. Okay, moving on to something completely different. Dermatology. I always love shoving in a few images and seeing faces go really pale and and very worried. So, what are we looking at? Any clues? Any ideas? Wonderful. What are you going to do in finals? Describe it. Yeah, perfect. So how are you going to describe it? This is the back of the knees, by the way. It took me a long time to work out whether it's elbows or knees, but perfect. Yep. Lovely. Perfect. Yep. Lovely buzzwords. Any more? Yep. Wonderful. Yep. Do you remember lichenificated? No? That's like the thickened appearance that you get from repeated excoriations. Lichenification. They love that. So I'd say some of that. They normally like you to come up with a differential as well, so always just have maybe a couple that you could talk about. You could talk about flexor psoriasis, but this is pretty obviously that it's, bog standard eczema. And how would you manage it? Lovely, yes. Emollient, emollient, emollient. Yes, that'll work. Treat. Anything else? Pardon? Try not to wear clothing. Yeah, I think you'll have difficulty selling that to patients because they like to cover up their eczema, really. But yeah, I can see your point. Anything else? Pardon? What's that? Yeah, that's good. Yeah. So we don't use soaps, we use soap substitutes. Brilliant. Any others? Any others? Do you remember wet wraps? No? Yeah? So young kids just get covered in basically cling film to try and encourage more moisture into their skin. Yeah? How about topical tacrolimus? Remember that? So we're talking about much further down the line now in terms of therapy, and then eventually you might get to the point of, in very rare cases, systemic immunosuppression. We also give treatment for superimposed infection. So obviously antibiotics or antifungals if warranted. Okay, perfect. What's this? This is an area on one side of the face only. Oh, you're too good. Well done. What else could it be? Lovely. Excellent. Can somebody, for bonus points, tell me the difference? Lovely. Brilliant. Very, very good. How would we treat this? Does anyone know the bug? This is actually erysipelas, this is strep. Group A strep. Normally pyogens. Treatment-wise, any clues? Now that I've told you it's strep, anything else? Penicillin. Yep, penicillin B. Wonderful. And particularly in this patient, what complications should we watch out for? Yeah? In what way? Brilliant. Okay. So here, very much have to watch out for periorbital cellulitis. Bonus points, what's the difference between periorbital and orbital cellulitis? Yeah. So periorbital is preseptal, doesn't involve ophthalmoplegia, don't have any visual loss. Orbital cellulitis is a medical emergency and requires IV antibiotics. Periorbital does not. Okay? With the orbital, well, you get ophthalmoplegia, so you would get I'm losing my words now. You would just sort of get unclear images. And if you got eventual compression of the optic nerve, you'd actually get visual loss. But I'd hope you wouldn't get quite that far. Okay. Uh-oh. This one? Now, most of the stuff that's put in here I think is fairly bog standard for finals, but there are the occasional things that are just to push the particular brain boxes. Any ideas? If you get stumped with something really odd in finals, which can sometimes, rarely happen, you've just got to talk your way out of it. So a lot of marks will come from describing and coming up with a differential. Yeah? So any ideas? Mhm. Yeah. Mhm. Mhm. Yeah. Lovely. It could be. It could be. Yeah. I can see where you're coming from, but yeah. Any other ideas? I think I heard one of the differentials in there from someone muttering somewhere. Yeah. No, not quite. What's the characteristic lesion with erythema multiforme? Yeah, no, sorry, probably can't see clearly enough on this, but no, there's no target lesions there. Yeah, how about if I tell you this is a herald patch? Does that help? No? Okay. So this is pityriasis rosea. Has anybody heard of it? Viral-induced rash that is self-limiting. However, steroids can speed up recovery. There are various types of pityriasis. There's pityriasis versicolor, pityriasis, I can't remember the other strand. This is pityriasis rosea. It's self-limiting, and we don't need to do much for it, really. Oh, no idea, sorry. But yeah, it's normally truncal in distribution, and I think probably differentials would be guttate psoriasis. Yeah. Anyway, that was just a random one to throw in. What's this? Pardon? Ah, wonderful. It's a port wine stain. Brilliant. And what condition is it associated with? Pardon? Close. What's the... It is Sturge-Weber syndrome. Well done. Very good. What's Sturge-Weber's? That's alright. So this is a phacomatoses, okay, which is a neuro-ocular cutaneous syndrome, because it's all from the ectoderm. Remember embryology way back when? So what happens is in these individuals, they get malformation of their pia mater as well as their skin colour. And as a consequence, they get calcification, they can have seizures, neurodevelopmental delay, they can also get glaucoma, and that can result in ophthalmos, which is a really big eye. But this is out there, really, to be honest. It's just a port wine stain and bonus marks. If they throw it in, it might be, but this is associated with Sturge-Weber syndrome, but that's about it, really. This is a prescribing skills station. We had lots of prescribing skills in our finals, and this is one I think that everybody should probably know, because it can be a bit complicated if you're only thinking about it on the day. Most times, obviously, you have a BNF in front of you and you can look up whatever you need. But I do think there are a few things that it might be a good idea just to memorise, so you don't freak out and take so long trying to figure it out. Do you see what I mean? So, this is an 18-year-old female who arrives in A&E after taking an overdose brought in by her mother. What things do you want to know? Yeah. Yeah. Wonderful. Yeah, that would be good to know too. Yeah, wonderful. Yeah. Yeah. Excellent. Yeah. Exactly. I think sometimes in the suicide history you can completely forget that there may be physical ramifications of what they've done. So it's important to check to see whether they actually do have any physical symptoms of the drug that they've taken. Anything else? Perfect. Yeah? Yeah. Excellent. That's very good. The other things we were asked, always to ask about, we were told, I think some would say, would you do it again? How do you feel about it now? It's very, very important to know that. And also, we were always asked whether they owned a gun. And I think that's because if they do own a gun and you discharge them home, there's such a high mortality rate. I just think that was something that we were always advised to ask. But very much so ask about alcohol. That's a really good one as well. Okay, so basically, 75 is the number to remember. You need to work out how many milligrams she's taken herself. If it's at 4 hours, you need to do a paracetamol level. If you do it earlier than that, you're completely right. It's not a valid result. If it's over 75 milligrams per kilogram, it would be a good idea to start N-acetylcysteine, do the level at 4 hours, and then if necessary, stop it. Okay? The other thing is activated charcoal. I'm getting confused with the numbers, you see. And it's 150 milligrams per kilogram is the number to remember for that, if it's within 1 hour. So that has to be a pretty recent overdose for that to be helpful. Is that okay? So the 75 is the one to remember. And she's consumed 210 milligrams per kilogram. So we'd want to start her on N-acetylcysteine and then check the level in 2 hours' time, and then we can stop it if necessary. Yeah? This is just to help you with the prescription. This is clearly written in the BNF, but it is quite a lot of things to remember. And I just learnt that it was X number of mils, which you look up in the BNF is according to their weight. So you do need to know the weight for this, and it is a mils prescription. And the first dose is 200 mils, and it's always in 5% dextrose, and it's initially over the 1 hour. Then it's 500 mils over 4 hours, and 1 litre over 16. So those are the numbers to remember for that. And so there's 3 prescriptions to be made for N-acetylcysteine. But with her, as I say, you'd only get a little way through the second one before you'd get your level. But you'd prescribe. It varies on chart to chart. Where I was from, we had booklets for years, so we had a drug infusion section, so that's where we wrote it. This is just a few images, so I just want people to shout out what they are. It is a proctoscope. What do we use proctoscopes for? Yeah, we do. What's this? Pardon? H. pylori test. Excellent. And what do we put on that middle dot? What was that? Chap in the dark green blue shirt? Forgotten your name. I'm sure you've worked on a ward. Yeah, sorry. I'm sure yeah, biopsy. I thought I heard you say it. So it's a biopsy sample from an OGD that you place on the clay test. What's this? That's a Yankees-sucker. Lovely. What do we use it for? Brilliant. What's this? Wonderful. What's that? Very nice. Someone's been looking at their images or spending a lot of time in gastro. It's a Steng Blakemore tube. It's used for esophageal bleeds, for varices, to balloon out, to compress them in an emergency situation. What's this? Yeah, this is a rigid sig. What's that? That is a bronchoscope. They're very good for knowing the type. Especially bronchoscope, but that's a flexible endoscope. Yeah. What's that? Yeah, and it's unipolar. If it's dipolar, it's got two prongs. What's that? We got similar pictures of this actually. Band sclerotherapy for hemorrhoids. I'll forgive you for not knowing that one. What's that? The form, what type? It is indeed, it's got a little tap at the end. What's that? That's a what, sorry? What bag is this? Yeah. What's that one? Wonderful. What are they? Yeah, pessaries. What's that? Wonderful. What's that? What are they, sorry? What's that then? I put this in because we had a suturing station in finals, and they come in a suturing pack, and they come with artery forceps and needle holders in the packs, and unless you know this, you might use an artery forceps to hold your needle, and it's just so that you look a bit more slick. So the artery forceps are the ones with the curved end. It's all about the grooving, the cutting inside, but and the needle holders are the straight ones. What's this? Urinometer. Perfect. Right. How am I doing for time and stuff? Do you guys need to go? Are you sure? Okay. What's this? We'll do spot diagnoses now because I know you know how to go through it. Pardon? we talking about? Whereabouts? Where's the abnormality? Yeah, so what is this? What's happened? So which one's the heart border? This one or this one? This one. Change that. Yeah, that's the heart border. So what's this? Collapsed lower lobe. Excellent. Great. And can anybody remember the name of the sign? Hale sign. Perfect. Causes of collapse? Foreign body. Yep. Tumour. Wonderful. Pardon? Not really. Difficult when you manage cause collapse. Yeah, those are main types. I've actually seen mucus plugging cause collapse. But yeah, that's brilliant. Well done. This one? Left-sided pleural effusion. Excellent. Causes of pleural effusion. Cancer in TV. Brilliant. Is that for a unilateral pleural effusion or a bilateral pleural effusion? Unilateral. Causes of bilateral? Failure. Yeah, really good. Which is what you guys are not going to do. So, exactly. Basically, unilateral pleural effusions are more likely to be exudative. And how much protein do you have to be exudative? Yeah. And to be transudative? Yeah, brilliant. And what do we do for the bit in the middle? Oh, you guys are good. What's the, tell me what Light's criteria is. You do? Yeah. You do, you really do, yeah. So, Light said, never let sun go down on a pleural effusion. Dr. Elliott from the respiratory department told us only a couple of days ago. Basically, you should always tap pleural effusion in the day because you need to find out whether it's an empyema first and foremost. So, when we tap a pleural effusion, we take 3 sets of fluid. One goes to biochemistry, and we check it for pH, amylase, LDH, glucose, protein. We take another sample that goes to cytology, and we do a third one that goes to microbiology for acid-fast bacilli for TB and MCNS, sometimes a fungal culture if that's what we're suspecting. Light's criteria is the ratio is 0.5 is the ratio to remember, but I find it really confusing trying to visualise which way round it is. So sort of just try and remember that the pleural fluid, if it has over half the serum protein, then that's exudate. Yeah? So it's 0.5. So if you've got more than half the protein in the pleural fluid than you have in the serum, then it's exudated. Alternatively, the number is 0.6 for LDH. I find that a bit more difficult to visualise, if you see what I mean. And you just have to have one of these criteria for it to stand. Yeah? Okay. Really quickly, what are we looking at? What type of modality of imaging is this? MRI, perfect. T1, T2, which is which? Other way around. So this is T1 and this is T2. Fluid is black. Fluid is black. No. Oh God. No, you've got it right. I'm really sorry. I've got that completely wrong. This is T2 and this is T1. Fluid is black in T1 and fluid is white in T2. So there's a tumour here with surrounding edema, and you can see how T2 is more useful looking at fluid. Yeah? What's this? Oh, star, that's brilliant. What are the features? Yeah. Oh, wonderful. Very good. How do we treat it? Well, say this patient's got potassium of 7.2. I'm hearing lots of right stuff. It seems to vary trust to trust. I tend to go on the hospital guidelines, but essentially it's 10 mils, 10% calcium glucate or chloride over 10 minutes. So it's a slow IVI infusion. So it's 10, 10, 10, and 10. It's not in anything, it's just 10% calcium gluconate or chloride, yeah, over 10 minutes. Then it's 10 units of Act Rapid. Yep, that's exactly what the protocol says at Jimmy's. There is an argument that 50% of glucose is quite difficult to get hold of, plus it scleroses veins, so some people say 100 mils of 20% would sort of suffice, so whichever really, but I completely agree with you. 50% is fine. It's 10 minutes again. It's all over 10 minutes. But what's the important thing to remember about the calcium? Yeah, you titrate it to the ECG. So you keep the ECG on, you give one load, and then you see what happens. Okay? This is a real CT from someone I saw in Norwich. And I put it in mainly just to point out the main bits of anatomy, to be perfectly honest with you, rather than what it shows. Should we just run through quickly? What's this? What's this? Which kidney? What's this? Lovely. What's this whole horribleness? Yep. What's this? Vertebral body, yep. What's this? Do you see on this side? The aorta, lovely. What's this? Wow, wonderful. What's this? Gallbladder, lovely. So what's this? Any idea? Yeah. So the perihepatic collection. Now what's going on here? Is this the normal size? Yeah, it's really big, isn't it? And what's this? Does that look normal? No. It's really diffusely enlarged and horrible looking. And what's this? Should this be here? No, this is the air in the biliary tree. This patient had a pancreatic head cancer, which caused obstruction, which has caused the gallbladder to distend. And then he's perforated his gallbladder, and he's got pneumobilia and a perihepatic collection as a consequence. So he went to the theatre with biliary sepsis. I just put that in, but we were just basically just looking at main bits of anatomy, and I think that's the main point to remember about CTs, is perhaps not so much about it's big stuff really, like massively obvious AAAs, things like that really, or massive tumours to watch out for. So my top tips about this was to just get a book and do like 5 a day. You need to know a bit of anatomy, but it's really big stuff. You know, rather than anatomy exams, it's quite barn door things that are generally asked. And this is what I said earlier, have a systematic method, but do be prepared to just be able to spout the diagnosis if prompted. And you just have to allow the examiner to lead you on that front. And if you don't know what you're looking at, just talk your way out of it. There's no negative marking. So you may as well keep talking, yeah? And just describe what you're looking at, yeah? This is the end. This is my last slide. This is just some general tips. I formed a nerd sock quite early on, probably too early on, kind of a bit irrelevant so early on really, but I really would recommend from now on in having a close group of friends and just revising with them a couple of times a week, and just sort of have random topics picked out. What we used to do was play roulette with cheese and onion, and you just flick it through and whatever it landed on, you know cheese and onion? No? Sorry. You know the Oxford Handbook, Clinical Sciences, so it's green and yellow, we used to call it cheese and onion. Okay, never mind, that's just weird. It's just a knowledge thing. But yeah, if you flick through a book, land on the page, and then just quiz each other on that front. My other point is that it is a marathon, and don't be persuaded to cram last minute. It doesn't help. You've got 5 years of information in your head. You won't manage to put in 5 years worth in the last week. You know, it's not going to happen. So you'd be far better pacing yourself now and not working yourself up into a frenzy right at the last minute. I think I'm safe to say that if everybody wants you to pass finals, the examiners are on your side. They're not there to fail you. They want you to pass. They've had you in med school for 5 years. They don't want to suddenly say, right, no more. So have that in your back of your head and know that they are there to help you, and allow them to guide you if necessary. Obviously, you know, if you're going off the wrong path, don't go in there with a fixed idea about what you're going to be asked to do. Be prepared to be flexible. The other thing is, don't be persuaded to do what everybody else is doing, or what your friends are doing, or because they've spouted some random bit of knowledge from somewhere. Oh my God, why didn't I know that? If you don't know it, it's probably small print, and finals is not there to test small print. It's there to make sure that you're a safe F1 on the first day of work and no more. They're not expecting you to be consultants. And the other piece of advice I'd have is that it is a performance, and there obviously is a huge amount of knowledge that you need to know going into finals, but I would say my biggest piece of advice is to show off, is to perform, and it is a performance. It's about looking the part, really, and going in there with a clear head and showing what you can do, speaking with authority without sounding arrogant, and being concise and to the point, not waffling. That's about it, really. That's it. Keep calm and be awesome.